Thank you, Andreas. Again, a privilege to be here. Many thanks to the organizers and to Diana, too, for keeping us honest and getting all our things in on time. It's a big job. So I'm going to talk about hip MR arthrography, but in quite a different light. And it's going to be about everything except the labrum. We've just heard some interesting talks from Gustav and Imad about the labrum, and I'm going to talk about everything else. And there is going to be some overlap with some of the other presentations today, so please bear with me. I find I have to hear things a couple of times in order for them to sink in, so do forgive me if there's some overlap. So just a couple of my disclosures. So what are we going to do here? Well, we're going to use a case-based approach. This is something in radiology that's become very popular in educational scenarios, to learn from cases. So we're going to look at about 10 cases if there's time. We're going to look at non-labral and extra-articular sources of hip pain that present with in patients who have MR arthrograms. And then we're going to look outside the sort of musculoskeletal structures as well, and look at causes of pelvic pain that may mimic labral etiologies. And finally, in terms of World Cup, as Ernest mentioned in his talk, it's not hard for me as a Canadian to predict that Canada will not win the World Cup in 2014. So I can at least be assured of one thing. So let's talk about, first off, non-labral sources of hip pain within the musculoskeletal system. So we do about 15 to 20 MR arthrograms per week in Vancouver, usually under fluoro. We sometimes do use ultrasound. All the images you're going to see are at 1.5 Tesla, which we find to do a reasonably good job. So our first case, this is some overlap with Dr. Nabil. This is a 44-year-old male. Over a 1-year history of persistent right hip pain. And all these cases I'm going to show you, the bottom line was rule out labral tear. That's what the rec said. So we can see that we do have some high signal. This is a T2 fat suppressed sequence. And in fact, this is too. And we see some high signal out near the superior lateral acetabulum. And we've seen this before. We saw this yesterday, and when Dr. Nabil discussed partial avulsion of the reflected head of rectus femoris. So I'll go through this a bit more quickly. The images we just saw demonstrate this high signal at the attachment of the reflected head of rectus femoris at that part of the acetabulum anterior superiorly where it originates. Now this muscle is at high risk for a tear because it crosses two joints. One of my colleagues likens it to having two full-time jobs. You're going to get into trouble sooner or later, and rectus femoris crosses the hip joint and the knee joint. Kicking sports, as we know, are the most common sports to be involved with injury, and the presenting symptoms you're all well aware of, groin pain with active knee extension when the hip is extended, kind of like a kicking motion. So the anatomy, again, well described before. I'll just direct you again to the indirect head of rectus femoris, arising as we've seen. And it actually turns out to be the most commonly injured of the two heads. And that is not something I don't think that radiologists, at least radiologists generally, are aware of. Clinicians maybe much more so. And of course, we know the function of the rectus femoris. This audience needs no reminder about where it inserts. So in each of these cases, I'm going to give you a couple of take-home points. So in this case, it's important for radiologists to always include one plane of a fat-suppressed, fluid-sensitive sequence in order to pick up things like this. If you don't, and just use T1 fat-suppressed sequences to show the contrast, you'll miss other pathology in the musculotendinous units, whether they be tears or tumors, etc. And also, I think another take-home message is that the direct head seems to get all the attention, at least from radiologists, from the point of view of rectus femoris. Okay, second case, 33-year-old female. The x-rays done views show possible hip dysplasia. Is there a labral tear? Again, very similar history as before. And what we see in this case is lateral to IT band, tensor fascia lata. On the fat-suppressed sequence, we see this elliptical collection. Now here's the T1 fat suppressed sequence showing you that it has fluid signal on T1, but there's some bright stuff here, some high signal stuff, indicating that there's either fat or blood or something like that, complex proteinaceous material. And on the axial, we see it here. So what's going on here? I'm sure many of you recognize this as a Morel-Lavallée lesion. Just again to show you this collection. Here is the bright signal on the coronal series, T1 fat suppressed, and these internal elements suggest complexity to the fluid. So what's a Morel-Lavallée? Well, it's a post-traumatic hemolymphatic mass. It's a degloving injury due to basically shear force across a fascial plane. At the Winter Olympics, we saw actually about 6 or 7 of these, mostly because of falls on ski slopes. Lots of shear stress there. And what happens is basically the subcutaneous fat and underlying fascia cause perforating vessels to tear, and you get varying amounts of blood or lymphatic tissue or necrotic or live fat in this collection. And basically depends on the source of the bleeding as to how prominent the clinical presentation is. If it's arterial, then the lesion gets bigger quite quickly, presents early. If it's venous or lymphatic, it takes a longer time. And in these scenarios, it can mimic a malignant lesion. And finally, sometimes in chronic scenarios, a pseudocapsule can form. And sometimes in these scenarios, surgeons will operate, although generally these are conservatively managed. The imaging appearance will depend on the age of the internal blood products. Here's an example of an axial image with fluid levels indicating lots of compartmentalized blood. Again, note the location, typical location. And the pseudocapsule, again, can form. If it's thick, you could talk to your surgeon about the utility of surgery, but not usually done. But the key is the history of trauma and the location. Those are the things that tip us off to Morel-Lavallée and take us away from making the mistake that it's a tumor. So take-home point, in any post-traumatic scenario, whether it's distal biceps tendon tear presenting as a mass in the arm or Morel-Lavallée, if you know the history and location, you can avoid making a mistake on the clinical diagnosis. And finally, if you do have to prove something is cystic or solid, as you might in Morel-Lavallée, the only 100% guaranteed way to do it is by giving gadolinium. You can look at signal and compare it to muscle and all those things. At the end of the day, you have to give gadolinium and look for non-enhancement to show that it's not solid. Case number 3, this will look familiar from Imat's talk. This is a 24-year-old gymnast with pain and a clunk in the right hip, positive labral tests, MR arthrogram. And what we can see on these fat-suppressed series is perhaps something going on here at the attachment of the ligamentum teres to the fovea. It looks thick, it looks frayed. And this, in fact, is a nearly completely torn ligamentum teres. And the patient also had a bit of a superior labral tear. And another thing I wanted to emphasize is many of these patients also have labral tears as well as other pathologies. So it's important to bear in mind the entire imaging picture when interpreting the clinical side as well. So we can see again, we've got the yellow arrow showing you these, this tear, the expansion of the fibers, gadolinium inside the ligament itself. Normally it should be smooth, it should have a cord-like appearance. It sometimes gets a little bit expanded at the fovea. You need to be aware of magic angle, which we've heard of before, and I show you this example at the bottom, showing you T1 fat suppressed on the left, a little bit of increased signal, and this short TE sequence for magic angle, and on the right it's not there. So this is just artifact, so just be aware of that. And the mechanism is usually more high-impact sports, not so much soccer, but American football, hockey, these kinds of things, or martial arts, where there's a large range of motion required. So it can also occur in the face of osteoarthritis, in which case it's less important. You know, in a paper by Bird, one of the real, I think, pioneers in hip arthroscopy, he described teres ligamentum teres as being the 3rd most common finding, a relatively small series nonetheless. But I think it is more common than we as radiologists are aware of. In fact, it's not often made in terms of a diagnostic comment in a hip arthrogram report. Also, the symptoms are difficult to interpret. Deep anterior pain, rather nonspecific. It can be hard to sort this out. We already discussed what to look for in terms of the pathologic ligamentum teres, and it can be an indication for arthroscopy, so important to keep our eye open for these lesions. And again, the take-home point, these are not rare, but in our experience and those of my colleagues in MSK Radiology North America, not that commonly reported. 73-year-old marathoner. Now, why do we do a hip arthrogram in a 73-year-old? Well, this is a good question. We struggle with this. We see a lot of master athletes. This guy's a marathoner. And we usually will query whether or not an arthrogram is necessary. The sports med physician felt strongly, so we did it. And he, again, had labral symptoms. But you can see his labrum was normal, but he had a tremendous amount of bright signal on the T2 fat suppressed series on the coronal image, which clearly very abnormal bone marrow. There were areas of subchondral sparing, which I don't show in that image. We looked for a subcapital fracture, nothing there. No AVN, of course, as you can see from the image. A labral tear again was present, but likely not the cause of this, this gentleman's severe pain. Follow-up radiograph later was normal, and this represents one of an entity with several names: transient osteoporosis of the hip, regional migratory osteoporosis, transient bone marrow edema syndrome. Obviously, we don't really know the etiology here, with something with so many names, but we do know who it affects: men in their 4th to 6th decade, and interestingly, women in their 3rd trimester. When do you suspect this in MR? Well, when you don't see the subchondral pathology, the AVN, insufficiency fracture, when you do see areas of spared subchondral bone, and something that authors describe that we don't do, and that is delayed peak enhancement of abnormal bone marrow perfusion imaging. We don't generally do that. Again, it's got other names. Remember the differential considerations, including sometimes septic arthritis. We will often stick a needle in these joints. These patients have a lot of pain to make sure there's nothing going on in the joint. And again, you know, what is its etiology? We're not sure. It may be complicated by an insufficiency fracture, and it's conservatively managed. Take-home point: diagnosis of exclusion. Note the subchondral bone marrow edema that we see, and note that there's areas of sparing, and whether it's reversible phase of AVN is not clear. I'm going to go through this case quickly because Imad showed a similar example. This is a 29-year-old guy, cam-type morphology on a plain film, maybe some meridian joint space narrowing, but range of motion restriction that was more than expected from what we saw on the plain films. So T2 fat suppressed image, something going on here, isn't there, at the inferior medial femur. And again, on the T1 fat suppressed series, something looks very abnormal with the morphology there. So what we did, as you would with any lesion you're suspecting to be cortically based, is we did a CT. The susceptibility effects of MR at 1.5T prevent a good look at the cortex. This looks black. So it's better to do a CT in these scenarios. We do the CT, we see a typical scenario of a lytic nidus with a central sclerotic focus, classic for osteoid osteoma. Again, I'll just be brief about this. We know the age group that's affected, less than 30 years old. We virtually never consider the diagnosis of people over 30, men more so than women, and most of them are cortically based. And I agree with the previous comments by Emmett in that intra-articular lesions act differently. They can mimic septic arthritis and produce symptoms that are a little bit strange, and even some periostitis on a plain radiograph. There are no cases of malignant generation, but these are problematic lesions. They cause a lot of pain and respond well to the current therapy, which is CT-guided radiofrequency ablation, which we do a fair number of in Vancouver. So take-home point is many of our patients that we see, young athletes, are less than 30. So osteoma is in the differential, broadly speaking. And remember to get a CT for any cortically based lesion. The last case before I talk about, briefly finish up with some pelvic abnormalities, is this master track athlete, 52 years old. Again, symptoms of left hip clicking. In this case, the yellow arrow shows us some high signal in the gluteus medius tendon. The blue arrow, perhaps a trace of fluid in the greater trochanteric bursa. This represents something we see a fair amount in older patients, gluteus medius tendinopathy or partial tear. Often these are not athletes. They're often sedentary. In this case, it was a more active woman. And typically we see this bright signal on the fat suppressed series, which is at the insertion. Again, I agree with prior comments of Philippe. Know the anatomy. It's absolutely critical. And when you load a tendon, it depends, of course, on the age as to what happens. In adults, you get distal tears, and in skeletally immature patients, you get insertional avulsions. And again, this group does not need reminders about anatomy because you're all well practiced on that, but just a review of where sartorius, gluteus medius, iliopsoas, the adductor group, hamstrings, and rectus femoris, direct head originate. That's where bone is avulsed in skeletally immature patients. Okay, I'm going to finish off in less than 5 minutes on things that are not MSK, but are still visible on MR arthrograms. We use a field of view of about 18 centimeters, which gives us a look at the pelvis. And unfortunately, there are things in there that we need to record. They may or may not be related to the patient's pain, but we need to record them and make sure that they're further worked up. I'm not going to go into detail here, but you do see the uterus, the female uterus, in patients on MR arthrogram. You don't get a good look, but you see part of it. It's important to be able to know some of these abnormalities and at least suggest a pelvic ultrasound when you do see an abnormality of the uterus. Similarly, you can see, this is not infrequent, fibroids, as shown in the bottom diagram by the blue arrow, sagittal fat-suppressed T2 sequence, or adenomyosis, which typically has this heterotopic glandular tissue in a broadened junctional zone, classic MR-specific diagnosis of adenomyoma. So again, important to know these things. They're a little bit outside our comfort zone when we're in musculoskeletal radiology, but we need to be able to recognize them. It's all about satisfaction of search, as we call it in radiology. You're not done until you've looked at all the structures, not just the ones for which you were referred. A couple of ovarian lesions, a 3-centimeter mass here arising from the ovary. It's got fat suppression on 2 sequences. We recommend an ultrasound anytime you see an ovarian lesion that looks complex or more than 5 centimeters on a premenopausal woman. An ultrasound is a good thing to do. The ultrasound shows a classic dermoid, echogenic mass. Benign lesion, but important to know about. Another benign lesion that ended up being surgically resected was this lesion. On the MR arthrogram, we saw a multiseptated T2 hyperintense mass shown by the yellow arrow. Ultrasound evaluation was recommended, and we see this lesion here with some color flow within one of the septums, which looks a bit too thick. It's not a simple cyst, requires referral to gynecology, and a serous cystadenoma, a benign lesion, was resected. And finally, the last case, again, you can see we've done MR arthrogram here, but holy smokes, what's going on in the pelvis is a light bulb up there. This is a T1 hyperintense mass, and what we see in ultrasound on the bottom image is the classic findings of an endometrioma. That is fine internal echoes with through transmission. Through transmission is this bright stuff at the bottom. So again, by doing the ultrasound, we've found a lesion that may or may not be responsible for pelvic pain, but still needs medical attention. So in summary, despite the relatively specific indication for MR arthro of the hip, there's lots of non-labral sources of pain. May or may not be responsible for symptoms, but need to be recorded and considered clinically. And because we have the female pelvic organs, in particular female, in close proximity, it's important to know some basics about those organs and when to refer, particularly for ultrasound. And a structured approach to reporting an MR arthrogram will prevent you from missing some of these features. So I'd like to thank you again for your attention, and happy to entertain questions at the break.